diabetic ketoacidosis, hyperosmolar hyperglycemic state, hypoglycemia. So these three are the acute metabolic complications of the diabetes. To learn how to identify, treat, and prevent these crises. So diabetic ketoacidosis and HSS, these two are very, very common in our society. Because of the increase in number of the diabetes, because of the uncontrolled nature of the diabetic management. To learn how to identify, treat, and prevent the hypoglycemia. See, hypoglycemia is much more dangerous than the DK and HSS. So it's always ideal to know all the, to tell to the patient that what are all the symptoms of the hypoglycemia, so that he can identify the hypoglycemia by himself and he can control the hypoglycemia. Otherwise, this hypoglycemia will turn into the very severe hypoglycemia and sometimes the death also. So don't underestimate the hypoglycemia in all the diabetic individuals, especially those people who are on insulin therapy and those people who are on the sulfonylurea therapy. And to learn about some of the landmark clinical trials in the diabetes and how they have influenced the current practice. So these are the complications of the diabetes. They are divided into acute and the chronic. And the acute, you have the metabolic complications like DKA, HSS, hypoglycemia, and also lactic acidosis, maybe because of the prolonged usage of your metformin. And in India, we also have the acute complications like infections. See, the infections are very, very common in the diabetic individuals because of the hyperglycemic nature. And it could be as gram-positive infections or gram-negative infections, anaerobic infections, fungal infections. And there are certain infections which are peculiar to the diabetes, like your Foner's gangrene or the carbuncles, or gangrenous cholecystitis, or emphysematous pyelonephritis. So these are so common and exclusive to the diabetic individuals. Or in COVID times now, we have seen our eyeball infections. So that is your mucormycosis. So they are also very common in diabetic individuals. Or malignant otitis externa. And chronic complications, we will deal it in the next month, next class. So they are the microvascular complications and the macrovascular complications. Now let us spend some time on the DKA. See, this is a triad. DKA. D means diabetes. That means blood sugars will be more than the normal. Usually to cause a diabetic ketoacidosis, the blood sugar values should be more than 250. But in certain situations, even with the normal blood sugars also you can get the DKA. Two situations. One is pregnancy. The second situation is the people are on SGLT2 inhibitor therapy. So your dapagliflozin or empagliflozin therapy, even with the normal blood sugars also, you can get the DKA. So in general, 95 to 99% of the cases, DKA means blood sugar more than 250 milligrams. But even with the normal blood sugars also, in pregnancy, and those people are on SGLT2 inhibitor therapy, that is a dapagliflozin or the empagliflozin therapy, even a euglycemic DKA is also a possibility is there. Ketosis. Ketosis means your ketone body's positivity. So in all the diabetic crisis or in acute metabolic complications, you should check the urine ketone body's positivity. Okay. So sometimes you can send the blood to the hydroxybutyrate or acetate or acetate, but it's not possible in all the places. So that is your blood ketosis, whereas the urine ketosis is urine ketone body's positivity. And then acidosis, so you should get the acid blood sent for the acid base pictures. So in here the pH will be less than 7.4. So less than 7.4 is acidosis, more than 7.4 is alkalosis. In all the DKAs, your pH will be always less than 7.4. So there is an index case. A 16-year-old boy, like our Satish, was brought to the hospital with complaints of vomiting, abdominal pain, and breathing difficulty. See the vomiting, abdominal pain, and breathing difficulty. His parents state that he has been complaining of excess urination and thirst during the week prior to the admission. Just 1 week, history of excess urination and thirst, that is polyuria and polydipsia. On examination, patient is drowsy, acidotic breathing is present, BP 90/60, pulse tachycardia, respiratory rate is 28. So tachypnea, tachycardia, hypotension. Blood sugar 478. patient is known to have a diabetes, is not known to have the diabetes, and there is no family history of the diabetes. So what is the one important test you will do to make the diagnosis of your DKA? Excellent. So urine ketone bodies and your pH, that is your blood sent for acid-base balances. So what are the two important aspects of the treatment? You give the fluid therapy and the insulin. So the fluid therapy is much more important than the insulin therapy. So that is your hydration. So as the patient is dehydrated, so give the hydration in the form of normal saline. So don't give the ringer lactate or the 5% dextrose or even the DNS also. So always NS. Okay. So in NS, what is the percentage of your sodium chloride? Sodium 0.9%. So do you know 0.45% is also available? That is half normal saline. So you send the blood for the the electrolytes. Suppose if the sodium is more than 145 or more than the 150, then you can use half normal saline. Otherwise, between 135 to 145 or 150, you can use 0.9% as a routine normal saline. So that is also one important point. Otherwise, if you use the same normal saline in the presence of hypernatremia, so definitely these people will have more and more hypernatremia. So it's a state of the metabolic decompensation which occurs as a consequence of the severe deficiency of the insulin. So you know the two reasons of the diabetes. One is insulin deficiency. The second one is insulin resistance. But in DKA, what is the defect? It is more of insulin deficiency. So it's a severe deficiency of the insulin. So no insulin at all from the beta cells. So that is the reason they are getting the DKA. Why the adults are not getting the DKA? Because there is some amount of the insulin production is there. So even the some amount of the insulin production is sufficient to prevent the DKA in the adults in this case. So the essential components of making the diagnosis are the three things: hyperglycemia, ketosis, and acidosis. So this is the diagnostic criteria: your mild, moderate, and the severe. So in the mild, plasma glucose 250, moderate 250, severe 250. So what is the take home message? So just 250 is sufficient to get the severe DKA also. So whether it is a mild or moderate or severe, even at just 250 is sufficient. But in two situations, even less than the 250 is also possible. What are they? Pregnancy and the people are on SGLT2 inhibitor therapy. So that is euglycemia also can cause DKA in those two situations. So what is your arterial pH? Always less than 7.4. So up to 7.25, it is mild. Up to 7, it is moderate. Less than 7, severe. Okay. So your normally 7.4. 7.25 to 7.4 is mild. 7 to 7.25 is moderate. Less than 7 is severe. Okay. In that way, you have to remember it. Less than 7, severe. Up to 7.25, moderate. More than 7.25, mild. Then the bicarbonate. 15 to 18 is the mild. 10 to 15 is the moderate. And less than the 10 is severe. So usually in acidosis, no, you do soda bicarbonate. Okay, soda bicarbonate. Here. So usually in the DKAs, so don't advise soda bicarbonate immediately unless the pH is very, very low. Otherwise, these people will have a lot of the other complications. So soda bicarbonate 15 to 18 is the mild. In mild DKA, you need not give the soda bicarbonate. In moderate, it is about 10 to 15. In the severe, it is more, less than the 10. And what about the urine ketone bodies? They will be the positive. So don't think that 1 plus is mild, 2 plus is moderate, or 4 plus is very severe. Even 1 plus is also severe. So positive means 1 plus, 1 plus, 1 plus. So usually our thinking is in severe DKA, urine ketones will be 4 plus, or just positive means it's a mild DKA. It is not like that. So urine ketone bodies positive or not. So the severity depends on the other factors, not on the factor of urine ketone bodies. In the same way, the severity not depends on your blood sugars. Even 250 is sufficient. Maybe 350 blood sugar, but it may be the mild. Suppose 350 is the blood sugar and pH is 7.26 and the bicarbonate is 18. So what is your TKA? Is it mild or severe? Mild. Suppose the blood sugar is 250 but the arterial pH is 6.9. ketone bodies is 9. So it is severe. So don't give much importance to the blood sugar value and the urine ketone bodies positivity. So other things are also important to differentiate between mild, moderate and the severe DKA. And the same thing happens to the serum ketone bodies also. And osmolality is a variable and is a Yannian gap. More than the 10 is the mild, more than the 12 is the moderate, and more than the 12 is the severe. Mental status. In mild, it is alert. In the moderate, alert or the drowsy. And the severe, stuporous, comatose, or the drowsy. So this is how you have to differentiate between the mild, moderate, and the severe DKA. Mild can be treated as an outpatient also. All of you can treat a mild DKA. Even a moderate also you can treat, okay, with a little more attention. But severe DKA, one should be admitted in the ICUs under a physician's care and endocrinologist care. Okay, so this is very important, very important. And don't send all the mild DKAs to the higher centers. Even a mild DKAs you can treat with your IV fluids, normal saline, and with your insulin therapy. And watch for the complications of the DKA, like any ARDS or acute kidney injury or any pulmonary edema or any cerebral edema, etc. So then you can send the patients to the higher centers. Otherwise, all the mild DKAs can be treated by you people all. So what is serum osmolality? So that is sodium plus potassium multiplied by 2 plus glucose in milligrams divided by 18 plus blood urea nitrogen by 2.8. So that is your serum osmolality. So to get the serum osmolality, you need electrolytes and the glucose and the urea. Okay, sodium and potassium. You can suppose here the sodium is 135, your potassium is 4.5. So what is 135 plus 4.5? 139.5. So 139.5 into 2. So maybe 280 or 278. Okay. Plus glucose. Here the patient blood sugar is say 400. 400 divided by 18. So somewhere between maybe 20 or 25. Okay. So if you combine that to 240, 280 plus this 25, so almost 300. So the normal value 285 by 295. It is more than that, increased osmolality. So increased osmolality is very common in HSS. That is also there in the DKA, but in HSS the serum osmolality is very high. So this is a very important. So anyhow you are ordering the electrolytes, you know the blood sugar, and you are getting the urea and creatinine. So get the osmolality also. So this also gives you in the management. Okay. And the anion gap, what is the anion gap here? Sodium plus potassium minus chloride plus bicarbonate. This also you get it with your electrolytes test. So if you order the electrolytes, you get the sodium, you get the potassium, you get the chloride and also bicarbonate. So calculate here, the normal value is less than the 11 milliequivalents per liter is the normal anion gap. So corrected serum sodium is the measured serum sodium plus 0.016 into serum glucose in the milligrams minus 100. So this is a very good two formulas you should remember, the osmolality and the anion gap. So what are the causes for this DKA? In India, the most precipitating cause for the DKA is an infection. Number 1. Number 2 is the omission of the insulin. So maybe because of the fasting or the feast, so these people will omit the insulin because they are busy. So they get the DKA, especially the type 1 diabetes. So the two reasons for that to get the DKA in the type 1 diabetes are, one is the infection, maybe urinary tract infection or respiratory tract infection, etc. And the second and most important one is the omission of the insulin. Okay. So in all the DKA individuals, even they omit the 2 doses or the 3 doses, there are the high chances of getting the DKA, unlike the adults. So even the adults know, even though they omit the they miss the insulin for 4 doses or 5 doses or 10 doses or 20 dosages, they don't get the DKA because some amount of the insulin is there to be released from their beta cells, and that some amount of the insulin is sufficient to control the DKA. Whereas in type 1 diabetes, no insulin at all. So that is the reason to get the DKA in a type 1 diabetes. So that is the reason you should be very, very careful to the patient that they should not omit the insulin 1 dose or 2 dose or 3 dose. Otherwise, they will land up with the DKA. What are the other precipitating factors? Myocardial infarction, CVA, acute pancreatitis, alcohol intoxication, trauma, and drugs. As I told you, that SGLT2 inhibitors, etc. So these are the other precipitating factors. The two important precipitating factors are the infections and the omission of the insulin, and others are the myocardial infarction or CVA or acute pancreatitis, alcohol intoxication, etc. So that is the reason now some people know when they get the diabetic, when they get the myocardial infarction, they get admitted in the cardiac ICUs. When the blood sugars are very high, so they are in the cardiologists are worried because there may be a possibility of getting the DKA. So in the presence of the MI and the DKA, so the mortality will be very, very high. So that is very, very important reason. Okay. Usually occurs in the newly diagnosed or inadequately treated the type 1 diabetes. Rarely can occur in the poorly controlled neglected type 2 diabetes. So the mechanical failure of the pump in patients on the continuous subcutaneous insulin infusion pump therapy is emerging as a leading cause of DKA in the developed countries. So that is not there in our India, but still in India, so most of the people, some of the people are on the pump. So the pump failure also can cause DKA. So pump failure means no insulin at all. So they thought that the pump is pushing the insulin, but when the pump is failure, they may not get the sufficient insulin in the body. So obviously they get the DKA at the latter time. So this is a very, very important. Please spare your attention here. Pathophysiology of the DKA. Here insulin deficiency plus increased counter-regulatory hormones. These two are very important DKA. So here the three organs. The center one is the liver. On the right side you have the muscle. On the left side you have the fat. That is adipose tissue. So let us concentrate on the liver, the center one. So what will happen in the deficiency of the insulin? So there will be more and more glycogenolysis. So what is glycogenolysis? The liver stores the glucose in the form of glycogen. So when there is a deficiency of the insulin, so what will happen to this glycogen? That will be converted to the glucose. So more and more glucose into the body in the deficiency of the insulin. So neoglucogenesis. Okay. So not only from the glucose, stored glucose, the liver that makes the glucose from the fats and the amino acids. That is neoglucogenesis. And there will be decreased glucose utilization because of the absence of the insulin. So insulin helps you in promotion of the glucose entry into the liver, into the muscle, and into the adipose tissue. So by these three ways, you will have more and more hyperglycemia as far as the liver is concerned. Okay. What will happen when the fellow is in the severe hyperglycemia? So you will have glucosuria. So he will pass a lot of the urine. So the polyuria will be there, and urea will be, and the urine will be filled with the glucose. So that is glucosuria. And there will be the ketonuria, and there will be increased excretion of the water. There will be dehydration. So because of the dehydration, there will be the electrolyte imbalance. So there will be the hyponatremia or hypokalemia or hypomagnesemia, etc. And these will lead to the acidosis. So now we will concentrate on the fat. So as the liver, as the insulin is deficient, so what will happen to the glucose utilization in the fat? That will be reduced because insulin helps you in entry of the glucose into the fat cells. So there will be decreased glucose utilization. And in the insulin causes lipogenesis. Insulin deficiency causes lipolysis. So there will be reduced lipogenesis and there will be more and more lipolysis. So more lipolysis means more free fatty acids. So these free fatty acids are fats, ketogenesis. So ketonuria or ketonemia. So that will lead to acidosis. Okay. And from the muscle. muscles. Again, in the absence of the insulin, so what will happen instead of the entry of the glucose into the muscle? That will be reduced. So there will be proteolysis. So that is the reason they lose weight. Why the type 1 diabetes they lose weight? Because of the deficiency of the insulin. So the insulin causes protein synthesis. So insulin deficiency causes proteolysis. So the proteolysis means muscle loss. So there will lose the weight. So increased amino acids that goes to the liver and has a neoglucogenesis and then forms more and more glucose. See, that is your DKA pathophysiology. So the two things here, one is insulin deficiency and the second one is counter-regulatory hormones excess. What are the counter-regulatory hormones? Glucagon, growth hormone, cortisol, epinephrine, norepinephrine. So these 5 are the counter-regulatory hormones. So glucagon, growth hormone, cortisol, epinephrine, norepinephrine. So what are the signs and the symptoms of the DKA? So the hyperglycemic symptoms. So they are the polyuria, they are the polydipsia, and occasionally polyphagia also. Gastrointestinal, nausea, vomiting, abdominal pain. So in all the diabetic individuals, especially the type 1 diabetes, when they present with acute abdomen, always think of DKA, diabetic ketoacidosis. Of course, in acute abdomen for our setup, it could be acute appendicitis, it could be acute cholecystitis, it could be acute pyelonephritis, or it could be acute pancreatitis. Okay, so these things are maybe acute gastritis. So these are the things. Along with these conditions, you also think of DKA in a type 1 diabetic when they present with acute abdomen. Okay. Neurological symptoms, lethargy, malaise, headache, okay, weakness. So these are things are there. So these are all things. See, the symptoms develop over hours to the days. And respiratory symptoms. So rapid deep breathing. So we consider it as a Kussmaul's respiration. So the people will have tachypnea. Changes in the mentation, hyporeflexia, hypotone, dehydration, decrease in neck vein filling, orthostatic hypotension, poor skin turgor, soft and sunken eyeballs. Others, you will have the hypothermia, hyperapnea, smell of acetone in the breath. So all these symptoms develop over hours to the days. So we have the different symptoms. So some gastrointestinal symptoms, some respiratory symptoms, some neurological symptoms, some dehydration symptoms, etc. Okay. So this is the lab results. So you diagnose it's a DKA. Pain abdomen is something concerned with your stomach. So in the dehydration, so there will be the electrolyte imbalances. So these will develop like acute abdomen. Not because of your acute pancreatitis or not because of the other organs, mostly because of your gastric. Electrolyte imbalance. Yeah, good could be there. Gut ischemia is not that, sometimes it may be mesenteric occlusion or mesenteric vein thrombosis. So that is very, very rare. That could be another possibility. But here in acute abdomen and DKA, it is mostly because of the gastric electrolyte imbalance. See the results here. The blood glucose more than the 250. Urine ketone bodies are strongly positive. Bicarbonate less than 18, that is a mild, 15 to 18. 10 to 15, moderate. Less than 10, severe. pH less than 7.4. So 7.25 to 7.4 mild. 7 to 7.25 moderate. Less than 7 is the severe. Sodium, it could be the low, hyponatremia. It could be the normal. Sometimes it may be the high also, hypernatremia. In hypernatremia, use 0.45 normal, half normal saline. Whereas the normal and the low, you can use the 0.9. Potassium, in hypokalemia, normal, rarely hyperkalemia, unless the fellow is on a potassium sparing diuretics or the ACE inhibitors or ARBs. Otherwise, hypernatremia, hyperkalemia is very, very rare here. Phosphates, usually normal and slightly low, and creatinine and BUN usually mildly increased. In the same way, the total count also mildly increased in DKA. So don't think that This total count elevation is because of the sepsis. Even in the DKA, the total count may be marginally elevated. So in the same way, the creatinine and the BUN also mildly increased because of the dehydration. So once you correct the dehydration, again the urea and creatinine will be under normal levels. So what about the treatment? So intravascular volume expansion, that is the fluid therapy, is very, very important. So you have to give the maximum amount of the fluids, normal saline. Maybe 1 liter in the first 1 hour, maybe 1 liter in the next 1 hour, maybe next 2 hours, or maybe 1 liter in the next 3 hours or 4 hours, in that way. So it's a book says that at least you can give a 4 to 5 liters of the normal saline in the initial 6 hours to the 24 hours period. But be careful, beware of the pulmonary edema. So respect the urine output. So these two are very, very important. So respect the urine output. If the urine output is good, give the plenty of the normal saline. When the urine output is reduced, so that means the patient is going into the acute kidney injury. So in such situations, if you give the maximum IV fluids, the people will die in the hands of intensivists because of the pulmonary edema. Okay, that is very, very important. Correction of the electrolyte deficit, correction of the acid-base status, that is your pH, etc. And initiation of the insulin therapy to correct the catabolism and acidosis. Treatment of the precipitating cause, maybe the infection, you can treat with an antibiotic, or maybe the omission of the insulin, you are giving the insulin, etc. And clinical monitoring, the vital signs, urine output chart, and your glucose chart, and your pH, and your electrolytes. So these are very important. Use of the time scale flow sheet and the definitive protocol is essential. Don't use the sliding scale here. So sliding scale means you are following the blood sugars. You should be proactive, not the reactive. Okay, so that is the reason you have to give the good amount of the insulin before the person gets the hyperglycemia. So sliding scale means you are following the hyperglycemia. When the blood sugars are there, you are giving the insulin. When the blood sugars are normal, you are not giving the insulin. So what happens after a few hours? Again the blood sugars will go up. Then you are giving the insulin. That means you are reacting to the hyperglycemia. So what I mean to say, you should be proactive, so not to get the hyperglycemia. So that means you have to assess that you have to give the some amount of the insulin not to reach the hyperglycemic state. Prevent the complications is very, very important, and provide the education and the follow-up. This is very important. Patient education about the DKA and follow-up is very important. That means he has to take the insulin very regularly, and the follow-up with you is very important. So this is very, very important. So shows you the fluid therapy, shows you the electrolyte imbalances, shows you the acid-base balances, and then give the insulin and treat the precipitating cause, and then maintain the vitals, monitor the vitals, and then respect the kidney function, and then prevent the complications, watch for the complications, and then avoid the complications, and finally educate the patient not to have the future DKA, and also the follow-up is very important. So the mild ketoacidosis is an ambulant definition. Patient can ingest, can retain the oral fluids without the difficulty. So that is the reason you need not admit, because oral fluid therapy is also sufficient here. Oral hydration, small sips of the sodium containing fluids frequently. Insulin, usually you need around 0.25 to 0.5 units, may be repeated every 2 to 4 hours subcutaneously. Monitoring blood glucose every 2 to 4 hours. Check the urine ketones at least every 4 hours. Should be observed in the hospital for at least 6 to 12 hours. That is your mild ketoacidosis. ORS, you can use it. You can use it. But you have to respect the sodium and the potassium. So ORS, they contain a lot of the potassium. Again, when the fellow's blood sugars at that junction are normal, so the patient may get the hyperkalemia. Usually I don't give any ORS, only sodium salt. Only plenty of the oral fluids, that is sufficient. No, you need not give the sodium also. When provided the patient is having the normal sodium levels, so simple water is sufficient, or buttermilk is sufficient, or the milk. So these are very important. And then control the blood sugars with insulin, frequent insulin therapy. So that's sufficient. Moderate and the severe ketoacidosis, the patient cannot retain the oral fluids. So because he got the nausea, vomitings, here you have to admit him. And he needs IV therapy. And patient with altered mentation, again and definitely admitted. These patients need admission, preferably in a high dependency unit. IV fluids. So determine the hydration status. So hypovolemia, mild hypotension, or cardiogenic shock. So hypovolemic shock, administer the 0.9% sodium chloride or the plasma expanders. In mild hypotension, evaluate the corrected sodium. Cardiogenic shock, hemodynamic monitoring. So serum sodium is high or serum sodium is normal. So accordingly, you have to maintain it. So one thing is very clear. So when the fellow is in the moderate DKA or the severe DKA, so better to get admitted in the intensive care units, and definitely they will look after these fluid therapy and etc. And insulin, always give IV in all the DKA. Don't give the subcutaneous insulin because the patient is in the dehydrated. So in the dehydrated condition, when you give the insulin subcutaneously, the absorption will be poor. So I have given the 10 units or the 12 units, 30 units. So the absorption will be poor. The whatever the insulin you give it in the subcutaneous, that don't reach the capillaries. So definitely the people will get more and more hyperglycemia and will end up with a severe hyperglycemia or severe DKA. So in all the DKA, once you diagnose the DKA, always give intravenously only, IV route only. Intramuscular usually don't prescribe because already you are giving the IV fluids normal saline, and it's very easy to give the IV rather than the IM. Okay. So here the insulin regular 0.15 units per kg body weight is IV bolus and 0.1 unit per kg body weight IV insulin infusion. And if serum glucose does not fall by at least 10% in the first hour, you can double the insulin infusion hourly until the glucose falls by 50 to 70 milligrams per cent. So for example, your blood sugar is 500 at this juncture. So your weight of the patient is 80 kgs. So you can give 0.1 unit as a IV bolus. So that means 8 units. So 8 units of your regular insulin IV bolus and then 8 units as the drip IV infusion. So 8 units per hour. So next 1 hour you check the blood sugar. Suppose if the blood sugar is still 500. So that means your 8 units per hour is not sufficient. You have to increase the dose. So it may be 12 units per hour or 16 units per hour. In the next 1 hour you check the blood sugar. So next 1 hour the blood sugar is 400. So you are happy. In the next 1 hour the blood sugar is 300. You are happy. In the next 1 hour the blood sugar is 100. So then you stop using insulin. Then give DNS. Okay, so that's how you have to manage the DKA. So only 2 points is very important. Hydration is very important. Okay, you just give the 0.1 unit as the bolus straight away into the IV. Suppose if the fellow is 100 kgs, give 10 units as the bolus, and then same 10 units in the trip. So get the 50 units of the insulin in a 50 ml of the normal saline. So what about 1 ml? 1 ml is equal to 1 unit. So you require about 8 units per hour. So ask the sister to in the IV infusion as. That's all. So that's how you have to infuse the insulin. So every 1 hour you check the blood sugar. Suppose if the blood sugar is not coming down, you have to increase the dose of the insulin. Suppose if the blood sugar is very rapidly reducing, you have to reduce the dose of the insulin. Suppose if the patient gets the hypoglycemia, then stop using it and give the dextrose. Suppose if the blood sugars are under good control, maybe 150 or 200, etc. So you can maintain the same dose. That is how. So the fluids are very important. Insulin is very important. Then prescribe what is the cause for this DKA, whether it is infection or omission of the insulin. If the omission of the insulin is there, you need not give any antibiotic. Suppose if there is an infection like the fever or urinary tract infection or respiratory tract infection, etc., you have to use the appropriate antibiotics also. So when the serum glucose reaches the 250, so change to the dextrose to avoid the cerebral edema. So check the electrolytes, BUN, creatinine, glucose, continue the IV insulin. When the patient can eat, initiate the multi-dose subcutaneous insulin. So when the fellow is not having any dehydration corrected, and the patient is not having any nausea and vomiting, is able to take the solids, then you can convert to the subcutaneous route. Continue the IV infusion for 30 to 60 minutes after the subcutaneous insulin is begun to ensure the adequate plasma insulin level. This is a practical point. Okay. So just you have given the subcutaneous insulin, immediately it won't start acting. So it will take minimum 30 to 60 minutes for its therapeutic action. So that 30 to 60 minutes you have to continue the IV insulin infusion and then stop using the IV insulin infusion, continue the subcutaneous dose only. So general principles, all patients with DKA, they need the short-acting insulin, like your Actrapid, or the rapid-acting insulins, like your Lispro or the Aspart. It takes longer to reverse the acidosis than to treat the hyperglycemia. Okay, so hyperglycemia can be easily treated. If you give the maximum more insulin, so sugars will come down, but it will take longer time for control of the acidosis. That is the reason, even though the blood sugars are under good control, you have to keep the patient for few more hours or few more days to control the acidosis also. So regular insulin should always be used. Don't use the mixed insulins here. So don't use the long-acting insulins like your Glargine or the Detamir here. The only insulin you have to use is the rapid-acting insulin or short-acting insulin. Okay, short-acting insulin is your Actrapid or Insugen R, and rapid-acting insulin is your Lispro or the Aspart. Continuous low-dose insulin infusion, start an IV insulin pump are the preferred method. Benefits: reduce the risk of hypoglycemia and hypokalemia, decrease the risk of cerebral edema, no need to guess the dosages. Disadvantages: increase in nursing care. Procedure: starting dose 0.1 to 0.2 units. Expected drop in the glucose 75 to 100 milligrams per hour, 10% per hour. Monitor the glucose levels every 1 to 2 hours. When resuming the subcutaneous insulin, continue the drip for about 30 to 60 minutes after the initial dose is given. So this is the average electrolyte deficits in the DKA. The sodium deficit 500 millimolecules, chloride 350 millimolecules, potassium 300 to 1000, calcium 50 to 100 millimolecules, phosphate 50 to 100, magnesium 25 to 50. Okay. Check the potassium levels. When the potassium is more than the 5 millimolecules, don't give the potassium monitoring, don't give the potassium. So the potassium is available in the two ways. One is the oral form and the second one is injectable form. So potassium chloride. So that is available in the IV. And your oral potassium is also available. So usually you give only here the injectable one. So when the potassium is more than the 5, don't give the potassium supplementation. When the potassium is right side, less than the 3.3, hold the insulin, give the 40 millimolecules of the potassium per hour till the potassium reaches to the more than 3.3. Okay. So here one practical point here is hold the insulin when the fellow is in severe hypokalemia. So what happens if you give the insulin in the severe hypokalemia? There will be further intracellular hypokalemia. Okay. So insulin draws the potassium outside the cell. So that is the very important. So when the potassium is between 3.5 to 5, so definitely you can give 20 to 30 millimolecules of the potassium in every liter of the IV fluid, and target here is the 4 to 5 millimolecules. So the bicarbonate. When the pH is more than the 6.9, that is the most practical point. No bicarbonate. Just the pH is less than 7.4, 7.3, 7.2, 7.1. So don't give the bicarbonate. When it is less than 6.9, that means severe DKA. In mild and moderate DKA, no need of soda bicarbonate. When the severe DKA means pH is less than 7. So here the less than 6.9, you can give the bicarbonate 100 millimolecules. Dilute in about 400 ml of the distilled water and infuse at a rate of 200 ml per hour with 20 millimolecules of potassium chloride. Repeat the bicarbonate administration every 2 hours until the pH is more than the 7. Monitor the serum potassium levels. If the distilled water is not available, saline can be used here. 1 ampule of the 7.5% of the soda bicarbonate contains about 44.6 millimolecules of the soda bicarbonate. So here the take home message is only when the pH is less than 7.6.9, you can remember as a 7. Okay, so then only there is a need of the soda bicarbonate, and the soda bicarbonate has to be given in the distilled water or in the normal saline. Don't use the 5% dextrose or the Ringer lactate to induce the soda bicarbonate here. What are the complications? Age of the patient and depth of the coma are the best prognostic indicators. Okay, when the fellow is elderly, so chances of having the mortality is very high. And the depth of the coma. So when the fellow is deeply comatose, so that means a lot of the complications must be there. Maybe acute kidney injury, maybe ARDS, or maybe acute pancreatitis, etc. So it's very difficult to tackle such situations. Mortality is less than the 10%. But nowadays, no, the mortality is very, very low. To my knowledge, no, almost like negligible mortality. 100% we can treat the DKS, provided if they come in a right time. Death is usually due to the infections, arterial thrombosis, and shock, prolonged shock. Individuals at extremes of the age or those presenting the shock or coma are more likely to die. Cerebral edema, the primary cause of the death in the children, may be due to the rapid fall in the blood glucose. So that is the reason when the blood glucose touches the 200, 250, we give glucose. So not to have the severe hypoglycemia. So severe hypoglycemia will cause cerebral edema. That could be the cause. So early treatment with the mannitol or the glucocorticoids may improve the prognosis. So this is the chart of the cerebral edema. So IV fluids, ISO or hypotonic, insulin, correction of the ECF acidosis. So the fall in the ECF osmolarity, stimulate the glucose disposal, etc. So the finally these people will cause the cerebral death because of the cerebral edema in the DKA situation. So there will be increased osmotic gradient into the cells. There will increase entry of the water, and finally cerebral edema. So it's a very clumsy slide, but the thing is a summary of the management. On one side is the IV fluids, in the center it is the insulin, on the last it is the potassium. So the DKA management is fluid management, insulin management, and potassium management. So when the fellow is in the hyperkalemia, don't give potassium. When the fellow is in severe hyperkalemia, give the potassium. When the fellow is in severe hyperkalemia, so hold the insulin and give the potassium, and then you can give the insulin. So insulin, how much I told you. IV fluids also how much I told you. So management of the DK is give the normal saline, give the insulin, and see the potassium levels and act accordingly. So ECG before the admission of the potassium, when the fellow is hypokalemia or hyperkalemia, etc. Review the urine output, vital signs, neurological status, and laboratory data. Frequent assessment of the clinical status and repeat the physical examination. Protection of the airway in the unconscious patient. Nasogastric suction as indicated for the ileus, emesis, or obtundation of the vulnerable airway. Chest X-ray and other imaging studies as needed to rule out the pulmonary edema, pneumonia, etc. Search for and treat the precipitating cause, mostly the infections or the MI in the elderly. Hypotension usually responds to adequate fluid management. CVP monitoring in elderly or if the cardiac disease is present, so that helps you in fluid management according to the CVP. Frequent ECG monitoring for the hyper or hypokalemia. Cerebral edema, you can treat with the mannitol and dexamethasone, that is the steroids. Brain imaging to exclude other pathology when the fellow is more comatose, in spite of your insulin therapy, in spite of your potassium management, in spite of your IV fluids. So get an MRI. So rule out any CVA or etc. ARDS, 100% oxygen, avoid the fluid overload. Thromboembolic complications, treat if occurs, not prophylactically. Consider the mechanical ventilation to accelerate the carbon dioxide elimination in severe acidosis. So these are other things to be added. So that is the reason in a severe DKA, all these things are a possibility. So always get admitted in the ICU so that they take care of all these things. So whether the hypertension is there, when the CVP is needed, and frequent disease monitoring, cerebral edema identification, and then CT or MRI brains. Okay, ARDS management, embolic management, thromboembolic management, or mechanical ventilation. So these are all possible if the patient is admitted in the ICUs. So this is a very important slide. Tells you the potential pitfalls in the diagnosis and management of the DKA. So all of us should know this. A smell of acetone on the patient's breath may not be apparent. Many people are anosmic for the acetone. Okay. Fever may be absent in the presence of the infections. Peripheral vasodilatation causing the cooling. Okay. Blood leukocytosis. Neutrophil count may be non-specifically raised. So sometimes there may be elevated WBC. So don't assume that it is because of the infections, and then to start treating with the higher antibiotics. Maybe in all the DKA, maybe the leukocyte count also may be a little higher. And fever. So don't expect the fever in all the DKA patients, even though the DKA is because of the infections. This fever may be absent in the presence of the infections because of the peripheral vasodilatation causing the cooling. Serum sodium concentration may be falsely lowered initially by high lipid and the glucose levels. May appear to rise suddenly after the insulin treatment lowers the plasma glucose and the lipid levels. Potassium concentration may be temporarily raised despite the severe total body potassium depletion because acidosis causes potassium influx from the cells. Creatinine concentration may be falsely elevated, interference by the ketone bodies. Urine ketone testing may show negative or trace result when the lactic acidosis or alcoholic ketosis coexists with the diabetic ketoacidosis. Ketostic reaction may become temporarily stronger during the treatment of the DKA due to the conversion of the beta hydroxybutyrate to the H2S state. SGPT and SGOT may be non-specifically raised. So in the DKA, SGPT, SGOT may be slightly elevated. So don't think that it is all because of the liver involvement. In the same way, urea creatinine may be elevated. So don't blame the kidneys. Even the same, the total count may be elevated. So don't think that the patient is having a grass infections. So these are all possible. These are some of the pitfalls in the DKS. Euglycemic ketoacidosis, uncommon condition, characterized by profound acidosis and ketosis in the presence of modestly elevated plasma glucose levels. Euglycemia. Historically described during the starvation, pregnancy, alcohol abuse, and use of the ketogenic diet. So these four are possible for a euglycemic ketoacidosis: starvation, pregnancy, alcohol abuse, and use of ketogenic diet. Now being increasingly recognized as a complication of SGLT2 inhibitors therapy. So fifth cause is SGLT2 inhibitors. Okay. So keto diet. So your who is that fellow? Vijayawada. Where much in diet. So incidence rates among the users of the SGLT2 inhibitors range from 0.16 to 0.76. Particularly common in type 1 diabetes who are on SGLT2 inhibitors. Therefore, use of these agents is contraindicated in type 1 diabetes outside the research setting. So this is our SGLT2 inhibitors induced DKA. Management: stop the SGLT2 inhibitor therapy, start fluid replacement, and monitor the electrolytes and the ketones. Start continuous insulin infusion and dextrose infusion. So dear friends, so next few minutes we will concentrate on HSS, that is hyperosmolar hyperglycemic state. So previously it was called as HONK, that is hyperosmolar non-ketotic state. Here a female 82-year-old, diabetes of 6 years duration, on oral hypoglycemic drugs, is admitted to the hospital with history of confusion and focal fits. So elderly, 6 years history of the diabetic, present with confusion and focal convulsions. Ketosis absent, pH 7.37, very high blood sugars 780, sodium more than the normal 152, potassium normal, urea elevated 105. So what is the diagnosis and the management? So very high blood sugars, patient is in confusion. Okay, when you see the pH, it is less than the 7.4, 7.4, but it's not too low. Okay, and ketone bodies are the negative. So this is the HSS. Most commonly found in the elderly patients, elderly people with mild or previously undiagnosed type 2 diabetes. Usually 99% there will be the history of the diabetes, elderly, uncontrolled, very poor follow-up, with presenting with drowsiness, okay, etc. This is rarely undiagnosed type 2 diabetes. Often occurs in the elderly patients taking oral hypoglycemic agents who are inadequately monitored. Those living alone, hospitalized patients not receiving enough fluids. So these are the precipitating factors: infection, severe stress, either physical or emotional stress, hypovolemia, usually diuretic induced, renal failure, inadequate fluid intake, maybe because of the elderly, reduced sensitivity to the thirst, or incapacitation occurring at any age, can't get to or drink or water, etc. So these are the precipitating factors. Mostly age related, mostly it is infection, and then stress and strain, maybe because of the elderly, living alone, maybe the emotional or the physical stress. So here the insulin deficiency, liver and the muscle. In the liver, increase in neoglucogenesis, in the muscle, decreased glucose utilization. So that's what happens in your DKA also. So finally there will be the hyperglycemia. Whereas in DKA, there is also a component of fat cells, adipose tissue. Here that is omitted here. Okay. So the hyperglycemia. So hyperglycemia will cause glycosuria and then hypovolemic shock and the pre-renal azotemia. That is the reason urea was elevated. And here hyperosmolarity. So I told you how to get the hyperosmolarity. Okay, 2 into sodium plus potassium plus your blood sugars divided by 18. Okay, some people they include the BUN, and even if you don't include the BUN also, this is sufficient to calculate as serum osmolality. So cellular dehydration and coma and finally death. See, the death or mortality is much more in HSS when compared to the TKA. Because of here elderly, because of the very high blood sugars, and the third thing is the dehydration, very high dehydration here. Insulin is not completely absent. These patients have insulin and C-peptide concentrations higher than in patients with the DKA. So some amount of the insulin is here in HSS to protect them not to have the acidosis. So lipolysis may be directly suppressed by the hyperosmolar state. Here the primary features are severe hyperglycemia when compared to the DKA. There the DKA even the 250 milligrams is sufficient to cause the diabetic ketoacidosis. But here the blood sugars are usually more than 600, 700, 800, etc. And absence of the ketosis, so ketone bodies will be the negative. And there will be this profound dehydration, maybe 8 liters loss. In DKA, maybe 3 to 5 liters loss. Whereas here 7 liters, 8 liters. And a neurological manifestation. So they are drowsy, comatose, etc. So severe high, more blood sugar, no ketone bodies, more dehydration, and more confusion, etc. So you are dealing a case of HSS. Lack of ketosis and acidosis lessens the gastrointestinal symptoms. Due to lack of the acute symptoms, patients do not seek the medical care quickly. Therefore, the prolonged diuresis, prolonged dehydration, decreased renal blood flow, extreme hyperglycemia, and mentation changes. Compared to the DKA, milder GI symptoms, Kussmaul's respiration is rarely observed. Decreased mentation is the common. Focal neurological signs mimic the CVA, like hemisensory deficits, hemiparesis, aphasia, and the seizure. Okay. Lab, CBP, chest X-ray, cultures may identify the precipitating cause. Maybe usually again here the infection. Blood glucose usually more than the 600. Ketone bars usually negative or just slightly positive. Osmolality is usually elevated. And I told you how to get your osmolality. So 2 into sodium plus potassium plus glucose divided by 18 is your serum osmolality. And the normal one is 285 to 295 milliosmoles per liter. Relationship of osmolarity with the grade of the consciousness. So changes in the mental status do not occur unless the osmolarity rises above the 320 milliosmoles. So once your diagnosis is HSS, when the fellow is deeply comatose, so indirectly tells you that the patient is in very, very high osmolarity condition. Usually normal is 285 to 295. But changes in the mental status will occur only after it rises more than the 320. See 315, they are alert. Stoporose 343, comatose 369. Again, in the primary goal is the rehydration to restore the plasma volume and correct the electrolyte deficits, provide the adequate insulin to maintain the normal glucose metabolism, prevent the complications, treat the underlying medical condition, provide the patient or family education and the follow-up. So the education, the follow-up, fluid balance, insulin therapy, and precipitating cause like infections. So these are very, very important. As these patients are very elderly, so I have to think of the cardiac protection, renal protection, etc. So the fluid, depending on the patient's state of the hydration and cardiovascular status, start the patient on off normal saline. If the serum sodium levels are very low, then the normal saline can be installed. Hydrate the elderly patients with the caution because we have to protect the kidney. Patients need to be assessed frequently for signs of the congestive heart failure. So when you are over anxious and giving the IV fluids therapy, so you may precipitate the pulmonary edema. Patients with history of the cardiac disease should be CVP monitored. So that is best way of giving the IV fluids. Insulin, same guidelines are the DKA, that is about 0.1 unit per kg body weight as the bolus dose, and then the 0.1 unit per kg body weight as the IV fluids. Monitor the glucose and electrolytes every 1 to 2 hours. Decrease the insulin when the blood glucose reaches to 200 or 250 or 300 to avoid the cerebral edema. So here the treatment depending on your potassium levels, sodium levels, etc. And prevention, identify the high risk patients, educate the patient or family on warning signs. See, most of the diabetics living in the alone or in the old age homes, they are more prone because they are under a lot of stress and strain. So they are not being seen by the regular doctor frequently. So these are the people who get the HSS. Now this is a very good slide, shows you the comparison of the salient features. Your DKA and HSS. Age usually less than the 30 years DKA. So mostly the type 1 diabetes. So more than less than the 30 years, 20 years. HSS, elderly individuals, mostly the type 2 diabetes, more than the 60. Symptom duration, it takes the days, few days in DKA because omission of the insulin will cause DKA. Whereas HSS is not because of the omission of the insulin. It takes more than the 5 days. Glucose levels, DKA, usually 250, 300. Here usually more than the 600. Sodium normal or the low in DKA. In HSS, they are the normal or the high. Potassium, more or less the same. Bicarbonate, in DKA it's very low, whereas HSS within the normal limits. Urine and the serum ketone bodies, they are positive in DKA, usually negative in HSS. pH is very low, whereas within the normal limits. Osmolarity less than 350, here more than 350. Normal is 285 to 295. Cerebral edema often subclinical in DKA, not evaluated in HSS. Prognosis 3 to 10% mortality in DKA. I think now maybe less than 1%, but HSS 10 to 20%. See the difference in the mortality. Very high mortality in elderly people who get the HSS. Subsequent course insulin is required in DKA because it is of type 1 diabetes mostly. Whereas in HSS, initially you require heavy fluids, initially you require high amounts of the insulin, but after that, again you can stop the insulin, go back to the OHS. So that finishes our DKA and HSS. Now move on to the third acute metabolic complication of the diabetes is the hypoglycemia. Here is a case study. A 44-year-old male had type 2 diabetes for the last 6 years and is on glibenclamide 5 milligrams twice daily and metformin 1000 milligrams daily. Fasting 96, postprandial 126. A1C 6.4. He complains of headache, inability to concentrate, and nervousness at around 5 p.m. every day. His symptoms disappear after taking coffee with the biscuits. So what is the cause for his symptoms? How will you prove the diagnosis? What precautions will you take in this patient? So he is just 44-year-old with just 6 years history and he is on 2 drugs. One is sulfonylurea, that is the glibenclamide, 5 milligrams BD, and the second one is the metformin, so 1000 milligrams per day. Sugars absolutely normal. Fasting 96, good control. Postprandial 126, very good control. HbA1c 6.4 is also very good control. But he is having hypoglycemia at 5 p.m. So that is hypoglycemic symptoms. This headache, inability to concentrate, nervousness, tremors, palpitations, okay, hypersweating. So these are all symptoms of the hypoglycemia. So these are the how will you prove this diagnosis? By examination of the blood sugars. So that may be 40 or 50 or 60 at that time. And the correction by taking the coffee with the biscuits. So it is correcting. It is correcting. So it's a pakka hypoglycemia getting at 5 p.m. every day. So what are the hypoglycemic agents he is getting? He is getting 2 drugs. One is sulfonylurea, second one is metformin. So sulfonylurea dose is higher here, 5 milligrams BD. So you can reduce the 5 milligrams OD and metformin continue the same dose. So that's how you can correct the hypoglycemia here. And then ask the patient to take the foods at the right time, regular times, maybe evening snack. So this is the Whipple's triad, hypoglycemia. So triad means 3 things. One is symptoms of hypoglycemia. You know what are the symptoms of the hypoglycemia. The second one is documented low blood glucose. That is with your glucometer, you can diagnose you can document that. And then recovery with the administration of the carbohydrate. So this is the Whipple's triad. So this is the classification of the hypoglycemia. The absolute glucose value less than 70 is considered as an alert value, that is hypoglycemia, level 1 hypoglycemia, for therapeutic dose adjustment of the glucose lowering drugs in clinical care and is often related to the symptomatic hypoglycemia. So that is your bookish class hypoglycemia. So what you mean by the hypoglycemia? What is the amount of the blood sugar to cause hypoglycemia? Less than 70. The second one, level 2 hypoglycemia, that is clinically significant hypoglycemia, when the plasma glucose is less than 54. Severe hypoglycemia requires assistance of another person for administering the carbohydrate or the glucagon. So the severe hypoglycemia. There is a mild and moderate hypoglycemia. They can correct the hypoglycemia by themselves by eating something. Whereas in severe hypoglycemia, the patient is in comatose condition or is drowsy. So where he requires administration carbohydrate. Documented symptomatic hypoglycemia. So symptoms of hypoglycemia with an accompanying measured plasma glucose values suggestive of hypoglycemia. It's a documented symptomatic hypoglycemia. Asymptomatic hypoglycemia. A documented plasma glucose level suggestive of hypoglycemia without the symptoms. So that is also there. Asymptomatic hypoglycemia. His blood sugar is low, but he is not having any symptoms of the hypoglycemia. And the probable symptomatic hypoglycemia. Symptoms of hypoglycemia not accompanied by the plasma glucose measurement, but which were presumably caused by the low plasma glucose levels. And last one is the relative hypoglycemia. That is presence of the typical symptoms of hypoglycemia at a plasma glucose level, not suggestive of hypoglycemia. So out of all these things, last one is very, very common in our society. So don't be hurry in reducing the blood sugar so quick. See, this diabetes is a lifelong disease. So from 500 to, don't reach the 150 within the 2 days or the 3 days. So slowly you can taper the dosages. Even though he gets the hypoglycemia, so tell to the patient that this is only the relative hypoglycemia. So don't eat much. Okay. So what advice you give to the hypoglycemic patients when you are having the hypoglycemia? Eat something. So at the 200 milligrams of the blood sugars, if he gets the hypoglycemia and if he eats some sweets, so what will happen to his blood sugars? Again will go to 300 or 400. Okay. So that is the relative hypoglycemia. So this shows you the symptoms of the hypoglycemia. The sympathetic and neuroglycopenic, both are common in diabetic individuals. So sympathetic is very common in young hypertensives, and neuroglycopenic is very common in elderly hypoglycemic or diabetic with a long duration. Okay. So what are the sympathetic symptoms? These are all happy symptoms because the patient recognizes hypoglycemia by himself. So faintness, weakness, pallor, tremors, nervousness, anxiety, irritability, hunger, palpitations, tachycardia, diaphoresis, hypersweating. So these are all symptoms of the hypoglycemia, sympathetic hypoglycemia, and they recognize that these are all because of the hypoglycemia, and then they correct the hypoglycemia by themselves. So that is sympathetic hypoglycemia. See the second half. Neuroglycopenic hypoglycemia, blurring of the vision, diplopia, lethargy, headache, inability to concentrate, loss of memory, confusion, focal neurological deficits, seizures, coma. So these are the neuroglycopenic hypoglycemia. In seizures and coma and focal neurological deficits and confusion and loss of memory, inability to concentrate, so they may not recognize the hypoglycemia and they need someone's help. So they need admissions. They need intravenous administration of the glucose. So that is neuroglycopenic hypoglycemia. See, this is the glycemic threshold for onset of the symptoms of the acute hypoglycemia. Mild neuroglycopenia, sweating, tremors, activation of the autonomic symptoms, cognitive dysfunction, severe neuroglycopenia, convulsions, coma, death. Say the blood sugar coming down from 72, your bookish hypoglycemia 72, when it touches to the 16 or the 10, see the changes in the body. Mild neuroglycopenia, moderate or the severe or the autonomic dysfunction. So there will be cognitive dysfunction, convulsions, and finally death is also possible in severe hypoglycemia. See, sometimes some of the deaths in our elderly individuals in neuroglycopenic hypoglycemia, we thought that after the death it could be because of the massive myocardial infarction. Actually, the death is caused by the severe hypoglycemia, but the fellow is in severe sweating, profuse sweating, okay, diaphoresis, and death. So we thought that it could be because of the acute myocardial infarction or unrecognized myocardial infarction or sudden cardiac deaths, etc. Maybe this is all because of the severe hypoglycemia. So that is the reason all elderly diabetic individuals, those people who are having autonomic dysfunction, those people who are having the neuroglycopenic hypoglycemia, so keep the blood sugars at a higher level. Don't invite the hypoglycemia in these individuals. So I think for a 30-year-old male or the female, our goal of HbA1c is 6.5. Whereas at 80 years or 85 years, it is not 6.5, maybe 7 or 7.5, even 8 also. So when you are achieving the very, very tight blood sugar, so you are at high risk of getting the hypoglycemia. So when you are getting the high risk of hypoglycemia, neuroglycopenic hypoglycemia, when he is alone during the night time, it is very difficult to recognize the hypoglycemia or to treat the hypoglycemia by IV infusion of the fluids. So the patient may die because of these values. Okay. Metabolic responses to the hypoglycemia. So the function of the various glucose sensors which are able to measure the blood glucose levels. Stimulation of appetite and food seeking behavior to encourage the food intake. Ability to release the glucose from stores, especially hepatic glycogen, which can be used even in the absence of the food intake. Regulation of the insulin secretion so that during fasting, secretion is quickly reduced with the falling blood glucose levels. So cessation of endogenous insulin secretion is the first hormonal response to the hypoglycemia in individuals with a preserved beta cell function. So when the fellow is in the hypoglycemia, so physiology, what is the first response? Stop insulin release from the beta cells. The signals will go to the beta cells. No, don't stimulate beta cells to release insulin. So already the patient is in hypoglycemia. So if the insulin is more, what will happen to the hypoglycemia? Much reduction, much worsening of the hypoglycemia. So that is the first thing. The second signal is stimulate the alpha cells. So once they stimulate the alpha cells, what insulin will release, what hormone will release? Glucagon. Glucagon is antagonist to the insulin. So more glucagon means more hepatic glucose production. So the more hyperglycemia. Again, more cortisol. That means more hyperglycemia. More epinephrine, more norepinephrine, etc. So the counter-regulatory hormones will release and insulin will stop. So that's how what happened in our physiology to counter-effect our hypoglycemia. The ability of the body to use alternative energy stores, especially fat, thereby conserve the glucose levels. Use of alternate energy substrates, ketone bodies, free fatty acids, and to a lesser extent lactate, glycerol, and amino acids. Conversion of some amino acids into the glucose by process of neoglucogenesis. Shift of metabolic processes from glucose as energy source to free fatty acids and the ketone bodies. See, this is the physiology of the counter-regulatory hormones. See the hypothalamus, pituitary, your growth hormone, ACTH, adrenaline, cortisol, see glucagon, see and cessation of the insulin production from the beta cells. So these all will happen in severe hypoglycemia. So these are all the metabolic effects of the counter-regulatory hormones. So in the proteolysis, they release more and lactate. So that will be converted to the glucose, neoglucogenesis. In the amino acids in the muscle, alanine. So that goes to the liver. And neoglucogenesis, so more glucose. So in the liver, you will have the glycogen storage. So there will be the glycogenolysis. So more glucose, more neoglucogenesis. In the same way, in the lipids, there is the lipolysis. So the free fatty acids, again, they will be goes to the liver and again converted to the glucose, neoglucogenesis. So these all will occur as a counter-regulatory hormones response to your hyperglycemia. Hypoglycemia in the type 1 diabetes is different from the type 2 diabetes. See, the mild symptomatic episodes are common and most likely to have before the meals and during or after the exercise. Around 1 episode a week in those on conventional therapy. Around 2 episodes a week in those on intensified treatment. So the more and more intensification of the insulin therapy, so you are inviting more and more hypoglycemia. Severe hypoglycemia, rule of thirds, applies to the adult type 1 diabetes and conventional insulin therapy in Western countries. 1 in 3 will experience the hypoglycemia coma at some point in his or her treatment. And 1 in 3 would have experienced a coma in the previous year. And 1 in 3 are incapacitated by frequent and severe episodes of the hypoglycemia. Because the most common agent to cause hypoglycemia is among the diabetic drugs, insulin. So insulin is the most potent hypoglycemic agent. So those people who are on type 1 diabetes, you need only insulin. So on intensification of the insulin, if he misses the dose, food, so definitely they cause hypoglycemia. Especially those people who are on Actrapid and on Mixtards, etc. Because you tell to the patient that you maintain about 30 to 40 minutes time duration between the food and the injection. So they have to take the injection first, and they have to wait for about 30 to 45 minutes, and then they take the food. So suppose if they miss the food after taking the injection, so definitely they will get the hypoglycemia. So that is the reason now the analog insulins are available. Your Lispro and Aspart, you need not wait. So within 5 minutes the action starts. So they take the injection and then they take the food. Or immediately after the food also they can take the injection. Suppose if they miss the food, so definitely they are missing the insulin also. So they don't get the hypoglycemia. Overall much less frequent than in type 1 diabetes, because type 1 diabetes we use insulin, so they cause more and more hypoglycemia. In type 2 diabetes we use the OHS. That too nowadays we are not using much of the sulfurias. We use metformin, we use gliptins, all the gliptins, we use the SGLT2 inhibitors, we use the O-glibose. So these all the drugs are not hypoglycemic agents. They are all anti-hyperglycemic agents. So the chances of getting the hypoglycemia is very, very less with these agents. So day in, day out, we are using metformin, SGLT inhibitors, gliptins, acarbose or the O-glibose. So these are not causing the hypoglycemia. But hypoglycemia is more common in type 2 diabetes when the fellow is on insulin therapy, or when the fellow is getting is on the sulfonylurea therapy. See the pharmacological hypoglycemia, insulin reactions, factitious insulin injections, sulfurias, ethanol, alcohol. So this is a very, very common drug. So alcohol in type 2 diabetes, they cause a lot of the hypoglycemia because alcohol makes the liver not to produce neoglucogenesis. So once in alcoholism, once the liver loses the capacity of the neoglucogenesis, so what will happen to the blood sugars? They come down. So that is the reason for the hypoglycemia in the alcoholic patients. Beta blockers. So beta blockers also cause hypoglycemia. Other medications, quinine, chloroquine. So usually in anti-malarial therapy, so they cause hypoglycemia. Phenolines, there ciprofloxacin, ofloxacin, catifloxacin, so they also cause hypoglycemia. Insulin-induced hypoglycemia, it is the commonest cause of hypoglycemia. Occurs 2 to 3 hours after the regular insulin, 8 to 10 hours after the NPH insulin, because they have the peaks. Less common with the glargine, detemir and the degludec because they are the peakless insulins. So the no peak with the glargine, detemir and the degludec, so no hypoglycemia. NPH insulin has the peak, so that has the hypoglycemia 8 to 10 hours after the NPH. Usually we give the NPH insulin, that is your insulatard, at 8 p.m. So after 8 hours means at 4 a.m. they get the hypoglycemia because of the peak in action. Suppose if you give the glargine at 8 p.m. they don't get the hypoglycemia at 4 p.m. or 4 a.m. Common causes of the insulin-induced hypoglycemia, insulin errors, reversal of morning and the evening dose. We tell the patient that take the 25 units in the morning, 15 units in the evening, but they take 15 units in the morning and 25 units in the night. So morning 15 units is not sufficient, so they are causing hyperglycemia. And the night time 25 units they cause hypoglycemia in the midtime. So this is very important. Reversal of the short and intermediate acting insulins. Okay. Improper timing of the insulin in relation to the food. That I told you. Excessive insulin doses. So this is very common in our hospitals. When you ask a sister to give 5 units, they give 5 ml of the insulin. Okay. So if you tell to the junior sister 5 units of the insulin, so they tell to the another sister to give 5 ml. Okay. So that is very common in general hospitals. So most common cause of hypoglycemia in the medical wards is excessive insulin usage dosage by the sisters. So you should tell very clearly that it has to be given only 5 units only, not the 5 ml. Whenever you give the instruction to the new sisters, you have to tell twice. It is not 5 ml, it is 5 units. So 5 units is different from the 5 ml. 1 ml is equal to 40 units. Suppose if you are giving the 5 units, so you are giving 200 units of the insulin. So what she requires is only just 5 units. So in that way, you have to tell to the your sisters for the proper injection of the insulins. So mix up of the urinary insulin, units 40 and units 100 syringes and the insulin. Now you have the two types of insulins are available, 40 units insulin and 100 units insulin. Okay, have you seen the 100 units insulin? No. So 100 units insulin is also available, and there is a pen, separate pen, that is 100 units pen. Because 1 ml, both are 1 ml. Here 1 ml is equal to 40 units. That's what you all know during your undergraduate period. Okay. Now the 100 units means 1 ml is the 100 units. Suppose if the patient requires 40 units. Suppose you are using the 40 unit syringe. So 1 ml you have to give it to get the 40 units. Whereas if you use the 100 unit syringe or 100 units per ml, so you can give only 1/4 of this value. So that is the advantage. So some of my patients know they require 60 units. So if you use the 40 units, you have to give twice. So with a 60 units, so with a 100 units syringe, with 100 units per ml, we can give it a single shot. So that is there. Now all the analogs are the cartridges. They are all 100 ml. They are all 100 ml. Erratic or altered absorption of the insulin, more rapid absorption from the exercising limbs. See, after getting the insulin, most of the people they rub. So when they are rubbing, they are making this insulin to act very fast. So then their chances of having hypoglycemia is very much is there. Suppose if they skip the food, so definitely they get very profound hypoglycemia, very rapid. So the predisposing factors: hypoglycemia, excessive insulin levels, excessive doses, or increased bioavailability. These are the predisposing factors: increased insulin sensitivity, inadequate carbohydrate intake, sulfonylurea induced hypoglycemia. 5% of all patients on sulfonylureas have the hypos. So most of our patients in rural India, they are on the sulfonylureas. So the 5% of our rural diabetes is very, very high number, very high number. So the predisposing factors mostly the age, starvation, hepatic or the renal disease, and adrenocortical insufficiency, potentiated by the alcohol and your salicylates. So other factors: exercise, acute accelerated absorption of the insulin, late inadequate repletion of the muscle glycogen, alcohol inhibits the hepatic glucose production, and some drugs will cause the hypoglycemia. Here a male 45-year-old, type 2 diabetes for the last 5 years. He is currently on a combination of the glimepiride 2 mg plus metformin 1000 mg twice a day. So he is getting glimepiride 4 milligrams a day and metformin 2000 milligrams a day. Fasting and PP 85 and 128. HbA1c 6.2. During a dinner party, he consumed 250 ml of the whiskey. He got up late in the morning with a severe headache, body aches, extreme weakness, palpitations, and perspiration. Glucometer shows fasting glucose at 10:30 a.m. was 45 milligrams. So what is the diagnosis? Hypoglycemia. What advice would you give to the patient? So this is all because of alcohol-induced hypoglycemia. So this alcohol is causing blocking the liver to cause neoglucogenesis. Okay. So this is the ethanol-induced hypoglycemia. Mortality rate in adults is the 10%. Leads to the severe hypos with the blood glucose levels as low as 10 milligrams. Predisposing factors: depleted hepatic glycogen stores, fasting prior to the alcohol ingestion. Treatment: IV fluids of the glucose, add vitamin B1 to glucose infusion. Because it's alcoholic, so use the thiamine. B1 is nothing but thiamine. So these are the beta blocking agents. The propranolol and other beta blocking agents usually cause the symptomatic hypoglycemia or mask symptoms of the hypoglycemia. Predisposing factors: chronic malnutrition, ethanol, and exercise. Mechanism of the beta blocker effects are unclear, but probably involve the inhibition of the hepatic neoglucogenesis, same as like your alcohol. Beta blockers can also inhibit the autonomic symptoms of hypoglycemia rendering the patient unaware of his or her hypoglycemia. This is the most important practical point. See, beta blockers, no, they reduce the tremors, they reduce the hypersweating, they reduce the tachycardia. So even though these are all the symptoms of the hypoglycemia, usually the patient is getting the hypoglycemia and he is getting the tachycardia, is getting the tremors, he is getting the sweating, etc. So these are all masked by the beta blockers. So he doesn't recognize that he is having a hypoglycemia. So he misses the symptoms of the hypoglycemia and then he will end up with very severe hypoglycemia. So the beta blocker therapy will mask the symptoms of the hypoglycemia. Unusual symptoms of the hypoglycemia. They are the lethargy, lack of interest in the surroundings, emotional lability, depression, and vomiting. So these are also other symptoms of the hypoglycemia. Depression. So chronic hypoglycemia. So definitely there will be the depression. Special problems. Hypoglycemia unawareness. That's already I told you. Nocturnal hypoglycemia. So very difficult to notice it. Reactive hypoglycemia. That is what I told you. That is the most common hypoglycemia in our areas. Hypoglycemia unawareness occurs with increasing duration of the diabetes, more common in those with the good diabetes control, may increase after an episode of hypoglycemia and after the sleep. So causes, they are the neuropathy, especially the autonomic neuropathy, cerebral function compromised by the neuroglycopenia, end organs may lose the responsiveness to the regulatory hormones, lack of sympathetic response, and off, that is hypoglycemia associated autonomic failure. So the management is the education, training in the recognition of the neuroglycopenic symptoms, review of the other aspects of the management, relax the control of the blood glucose. So you keep the blood sugars at higher level, your targets. Hypo awareness may return after a few weeks of the avoidance of the hypos. Nocturnal, early morning symptoms like headache. So always think of the nocturnal hypoglycemia. Nightmares, Somogy phenomenon. So I told you what you mean by the Somogy phenomenon. That is hypoglycemic, post-hypoglycemic hyperglycemia. So the nocturnal hypoglycemia management, measure the 3 a.m. blood glucose, bedtime snacks, reduction of the night dose of the insulin, relax the control, especially of the fasting plasma glucose, shift to the basal analog insulins. So as they are peakless insulins, they won't cause any nocturnal hypoglycemia. Reactive hypoglycemia, it is uncommon condition found in the early diabetes or the pre-diabetes. Insulin secretion shows an initial lag followed by the excessive starvation secretion. Symptoms of hypoglycemia occur 3 to 5 hours after a meal, usually found in the obese. Symptoms disappear when over diabetes develops. Weight reduction is most important, and small frequent meals can be diagnosed by using the extended OGTT. So you see here the values: fasting 96, 1 hour 188, 2 hour 139, 180. So this is the extended OGTT. We see at 240 and 300 hours. Okay, it is about 50 on the 71. So a similar picture may be found in patients who have undergone the gastric surgery also. Elementary hypoglycemia. What about the morbidity of the hypoglycemia? So neurological mostly, coma, convulsions, transient or motor or sensory deficits, hemiplegia, aphasia, ataxia, chorea. See the permanent brain damage, including the decortication, intellectual or memory impairment. So these are all could be possible of severe and prolonged hypoglycemia. Psychological, a cognitive dysfunction, behavior or personality change, automatism, psychosis, cardiovascular arrhythmias, myocardial ischemia. Okay, so hypoglycemia is much more dangerous than the hypoglycemia. hyperglycemia. I told you, no. So these are all the reasons to morbidity the mortality in hypoglycemia. Suppose if the patient is already had a diabetic retinopathy, etc., there will be the vitreal hemorrhage, musculoskeletal fractures because of the falls because of the unconsciousness, and accidental injury, including the road traffic accidents. So when the fellow is in the severe hypoglycemia, so there is a lack of concentration, leads to accidents. So this is the one case. If 62-year-old male, type 2 diabetes for the last 28 years. So very typical in our Indian diabetic. So age 62 years, but history of diabetes is 28 years. He is taking glibenclamide 5 milligrams twice daily, metformin 500 milligrams thrice daily, and pioglitazone 30 milligrams once daily. One day, he was brought to the emergency department by his son in an unconscious state. Okay. His son says his father is very systematic in taking the medications. Yesterday night also he has taken all the medications, your glibenclamide, metformin, pioglitazone, etc., and has taken his dinner, though he could not take his usual diet due to some stomach disorder. So that is the clinching point. He has taken all the drugs, but not taken the usual dinner. So maybe half of the dinner or 1/4 of the dinner. So capillary blood glucose done immediately was 32 milligrams. So he brought to the emergency department in unconscious state. So all the chronic diabetics, when they cross more than 20 or 25, 30 years, so they definitely present with the neuroglucopenic hypoglycemia because of autonomic dysfunction. So in such situations, if you don't see the blood sugar, so the patient is going to die. So here the diagnosis is mostly clinched by your glucose estimation. So 32, immediately you give 25% dextrose, immediately there will be a rapid correction of his blood sugars, and then definitely he regains his consciousness. Okay. So what condition is this patient suffering from? Hypoglycemia, but not adrenergic hypoglycemia. So that word you should tell right this juncture. Hypoglycemia, which hypoglycemia? Neuroglucopenic hypoglycemia, not adrenergic hypoglycemia. So adrenergic hypoglycemia, they don't come to the emergency department. They know that they are having the symptoms and they correct themselves by taking some sweet, etc. But this is neuroglucopenic hypoglycemia. The patient is in a comatose condition, brought to the hospital by his family members or his friends. So how will you treat this patient? With Edracaf, then IV fluids, 20% dextrose. What is to be done to prevent the recurrence of this condition? So this is very important. So your education is very important. Okay. So better to avoid sulfonylureas because sulfonylureas cause long-standing hypoglycemia, especially glibenclamide. So don't be happy after the correction of the blood sugar from 32 to 200 with 20% dextrose. Again, within 2 hours or 3 hours, again you will end up with the hypoglycemia. So the rebound hypoglycemia is very, very common with the sulfonylureas. That too long-acting sulfonylureas like glibenclamide, which is very, very common in rural India. Your glucored fort, etc. That contains the glibenclamide. So the glibenclamide induced hypoglycemia. So you have to observe the patient, admit the patient for at least 1 to 2 days. 1 to 2 days. That is very important. So what is to be done to prevent the recurrence of this condition? So education of the patient is very, very important. So what you mean by the hypoglycemia? What is glucopenic hypoglycemia? What is adrenergic hypoglycemia? What drugs will cause hypoglycemia? So when you are not taking the food, so you should not take the glibenclamide when the food is not taken at the right time. The metformin won't cause hypoglycemia. So the cause for this hypoglycemia is because of the glibenclamide. So treatment: oral carbohydrate, food, sugar, candy, orange juice, etc. In patients on alpha glucosidase inhibitors, complex sugars may be ineffective. Glucose has to be given. Okay. IV glucose 100 ml of 20% dextrose. Glucagon either subcutaneously or intramuscular, it is not available, but that can be used to tackle the hypoglycemia. So this is the treating the hypoglycemia. It's very simple. When the patient is conscious, you have the food. When the patient is not conscious, you have to give the IV glucose. That's all. Prevention strategies: regularity of the diet and insulin, exercise, And then most important in hypoglycemic patients is the diagnosis, SMBG. So they should have a glucometer and they should check the blood sugars. They should know which food is causing hypoglycemia, how much food is causing hypoglycemia, and how much time distance between the food and the insulin is causing the hypoglycemia. So these are all things has to be learned by themselves. So that is the SMBG. Here 88-year-old male living alone is brought to the hospital by his neighbors. Patient gives history of taking the treatment for type 2 diabetes for the last 12 years. Suffering from COPD, chronic obstructive lung disease. He is on metformin 2 grams per day. For the past few days, he has had fever and vomiting with breathing difficulty. Okay. On examination, patient is febrile. Blood pressure 128/78. Pulse rate 116. Respiratory rate 28. Investigations reveal blood glucose of 348. Urine acetone is negative. His blood lactate levels are elevated. So this is the case. So he is on metformin therapy. He is a COPD. He is in hypoxic condition. Okay. And his lactate levels are very much elevated. So suppose your diagnosis is HSS or your DKA. So you check the blood sugar, ketone body is done. That will be the negative. And your serum osmolality is the normal. Then you should think that it could be a case of lactic acidosis. So when the fellow is on chronic therapy of the metformin, in an hypoxic conditions like COPD, the chances of having the lactic acidosis is very high. And check the lactic acid. So that lactate levels will be very high. And this is a case of lactic acidosis causing diabetic coma. So I discussed about the DKA. We discussed about the HSM. And also discussed about the hypoglycemia. This is the lactic acidosis. But fortunately, so lactic acidosis cases are very rare. I have seen only 2 cases so far. Okay. And it's a high mortality, lactic acidosis. It's a very uncommon condition seen in critically ill patients, those with hepatic, renal or respiratory failure. It has rarely been linked with the use of the metformin. Hence, this agent should be used with caution in ill patients, critically ill patients. So metformin is contraindicated in hepatic failure. It is contraindicated in renal failure. It is contraindicated in hepatic failure or a heart failure, because in all these conditions there is an hypoxia. So if you use the lactic acid metformin in the hypoxic conditions, the chances of having the lactic acidosis are very high. So these are all the classification of the lactic acidosis. Type A, they reduce the tissue ATP due to the reduced tissue perfusion. That is a type A, lactic acidosis. Type B, there is no evidence of the reduced perfusion. B is divided into B1, B2 and B3. B1 is systemic disease like diabetes or renal failure, hepatic failure, etc. B2 is drug induced, your metformin or alcohol or INH. And B3 is the inborn errors of the metabolism. So that is the division of the lactic acid. You need not remember these things, but think that when the fellow is taking the long-standing metformin therapy, elderly with a COPD or in failures of the organs like hepatic failure, renal failure or cardiac failure, so definitely think of the lactic acidosis, get the lactate levels done. So these are the clinical features, lactic acidosis, cyanosis. So that is tissue hypoxia, cold extremities, tachycardia, hypotension, altered mentation, and hyperventilation. Lab findings, high anion gap metabolic acidosis, and serum lactate levels are very high. Treatment, hydration is important. IV bicarbonate is also the mainstay of therapy. Here the bicarbonate is the mainstay of the therapy. Dialysis can be done to remove the lactate levels, and 5% dextrosaline infusion along with the insulin can be given. See, this is a very good slide. Shows you all the 4 causes of the coma, acute metabolic coma. Ketoacidosis, DKA, HSS, lactic acidosis, and hypoglycemia. So what will happen to your blood glucose in ketoacidosis? And ketoacidosis, blood sugar increased. Okay, HSS, blood glucose increased. Lactic acidosis, maybe normal or increased. Hypoglycemia, very low. Okay. Again, in the blood sugars, the ketoacidosis, which one is much higher, ketoacidosis or HSS? Blood sugars, HSS, maybe 600 plus, 700, 800, etc. Okay. In ketoacidosis, is the blood sugar always elevated, even in the normal also? Normal also. In which conditions? Pregnancy, starvation, keto diet, alcohol, and SGLT2 inhibitor. So 5 conditions. Even in the normal blood sugars also you can get the DKA. Starvation, alcohol, pregnancy, SGLT2 inhibitors, and keto diet. Now the ketosis, ketonuria, ketone bodies will be positive. In DKA, yes or no? Yes. HSS, yes or no? Maybe usually negative, maybe partially, just 1 plus. Lactic acidosis, same thing. Hypoglycemia, starvation hypoglycemia, you will have again ketone bodies positive. Okay. pH in ketoacidosis, low, because it is acidosis. pH will be less than 7.4. HSS, usually normal or just low, maybe 7.39, 7.3, not like 7 or 7.25. Lactic acidosis, very low, very low. Hypoglycemia, normal, pH. Sodium levels, lactate levels, blood volume levels. So that's how these are all very, very important differentiation points between this. So when a diabetic enters into the emergency department of the coma, so you have to think of these things. So what about the blood sugar, what about the urine ketone bodies, what about the pH levels, what about your sodium levels, what about your potassium levels, what about the lactate, provided if you have the doubt of lactic acidosis, and then the dehydration, that the blood volume means dehydration. So very severely dehydrated, maximum dehydration is seen in HSS. So in a diabetic presence with a coma, need not be always because of the diabetes. Okay. So being a diabetic, so there could be some non-diabetic causes of coma also there. Okay. What are they? Stroke, and then cerebral trauma, alcohol intoxication, drug overdosages, or shock, septicemia, uremia, hepatic coma. Okay. So these are all the non-diabetic causes of the coma. So first think of the diabetic causes of the coma. What are the 4 diabetic causes of coma in a diabetic individual? DKA, HSS, hypoglycemia, lactic acidosis. So, and then these are other causes of the coma. Maybe a stroke, CVA. Maybe a patient is in the shock, sepsis, septic shock, or maybe in the uremia. See, last follow-up, elderly patient. So earlier the creatinine was 2. Now after 1 year or 2 years, and attended to the emergency department, maybe the creatinine may be 8 or 9 or the 10. So this coma is because of the CKD coma. So in the same thing, hepatic coma, etc. So these are the trials in diabetes, UKPDS, DCCT. They are trials on prevention of the diabetes complications, trials on the prevention of the type 2 diabetes, DAQUING study, DPS, DPP, that is Diabetes Prevention Program, trials on intensive glycemic control in type 2 diabetes, Acute, advanced VADT. Can good control of the diabetes prevent the chronic complications? So this is the UKPD study design. Conventional is intensive. So the more intensive, more reduction in the control of the complications. Benefits of the tight glycemic control. See, the lowering of the glycoted hemoglobin by 0.9%. You can think as 1%. Suppose 1% reduction in the HbA1c. So there will be the risk reduction of all these things. Any diabetes related endpoint by 12%, microvascular endpoint by 25%, myocardial infarction by 16%, retinopathy by 21%, albuminuria by 33%. See, significant reduction in all endpoints except the myocardial infarction, which is just failed to reach the statistical significance. Okay, you got the point here. Myocardial infarction reduction is not that high, that much reduction when compared to the other things when they control the blood sugars alone. So this shows you that myocardial infarction is a macrovascular complication. So to reduce the macrovascular complications, you have to reduce the other vascular risk factors also. What are the 5 vascular risk factors? diabetes, hypertension, smoking, obesity, dyslipidemia. Okay, and other factors like so there is a strong family history, or hyperhomocystinemia, or hyperuricemia, or microalbuminuria, or a ankle-brachial index, or a carotid intermediate thickness, or apolipoproteinemia. So a lot of the other risk factors also there for vessels. So to reduce the myocardial infarction, which is very common in our places, it is not the control of the blood sugars alone is not sufficient. So along with the blood sugar reduction, you should concentrate on the blood pressure, you should concentrate on the cholesterol, you should concentrate on the weight reduction and cessation of the smoking. So these are all very important to make the vessels to live for the long period. So for the vascular protection. So simple reduction of the blood sugar is not sufficient in a diabetic individuals to avoid myocardial infarction. Am I clear? So in all the diabetic individuals, you should see that A, B, C, D, E. I told you several times. So in the diabetes management, A, B, C, D is very important. A stands for A1C. B stands for blood pressure. C stands for cholesterol. D stands for your diet, your drugs, your doctor relation. Okay, so these are all very important. So then only you can control the mortality and the morbidity of the diabetes very effectively. Just the simple control of the blood sugar is not sufficient in a diabetic individuals. So these three are the trials: Acute, Advance, and VADT. Three trials designed to look at the effect of tighter than the tight glycemic control on chronic complications of the diabetes, particularly the cardiovascular disease. So tighter than the tight. Okay. This is a Acute trial. About 10,251 patients with type 2 diabetes. So that the conventional glycemic arm is 7 to 7.9%. Intensive arm is less than the 6%. But this trial was prematurely terminated because of the more and more cardiac deaths in the intensive phase. See, what is the intensive phase HbA1c target? Less than 6%. So when you keep the HbA1c at less than the 6%, more and more cardiac deaths because of the severe hypoglycemia. So hypoglycemia causing arrhythmias, hypoglycemia causing vascular injuries. So that is the reason. Because hypoglycemia, what will happen to your counter-regulatory hormones? They elevate. So cortisol, glucagon, epinephrine, norepinephrine, they are all damage the vessels. So that is the reason Acute trial was prematurely terminated, because in the intensive arm, when they keep the blood sugars HbA1c less than the 6%, more and more cardiac deaths. So in spite of achieving the HbA1c targets, there were more deaths in the intensive control than the conventional control. So this excess mortality led to the premature termination of the glycemic control of the Acute trial. So this is the advanced trial. At the end of the follow-up period, the intensive control group achieved an HbA1c 6.5% compared to the 7.3% for the conventional control group. So when you keeping the HbA1c at 6.5, not of much mortality. When you are aiming for less than 6%, more mortality. So lessons from these three trials. In all the three trials, the individuals who had lower baseline levels of the HbA1c or lesser severity of the complications did better with the intensive control. In all three trials, severe hypoglycemia was more common in the intensive control arms. In Acute, a significant proportion of the excess mortality was listed under the unexpected or presumed CVD category. The role of hypoglycemia in these events has not been evaluated for want of the data. In a VADT, the most powerful predictor of cardiovascular events was severe hypoglycemia. So my appeal to all of you is, don't introduce hypoglycemia in our diabetic individuals. That is much more dangerous than the hyperglycemia. Metabolic memory, already I told you earlier, the legacy effect. So what you mean by the metabolic memory? So the diagnosis of the diabetes should be done at the right time, much early. And then you have to control the blood sugars very effectively from the beginning. So initial days of the diabetes management is always good to avoid the long-term complications. Suppose you are diagnosing the diabetes right now, and don't lose the patient by poor control of the diabetes. If you control the diabetes very effectively in the initial days of the presentation, these people will stay long period without any complications. So the tight control of the diabetes pays off in reduced angiopathy and atherosclerosis and other complications years later, even if control has subsequently become less intense due to the mechanisms beyond the blood glucose levels alone. So what should we aim for? Individualize the therapy and the glycemic target. So all the treatments or the guidelines are there to guide you, but the treatment must be individualized. Do not aim to aggressively control the glycemia in old, very young and frail patients or those with other serious comorbidities. Be aware of the side effects of these drugs and prescribe them judiciously. Most patients with type 2 diabetes die of cardiovascular disease. Aim for comprehensive CV risk reduction, which includes the blood glucose, blood pressure, lipids, tobacco, etc. Tobacco cessation, etc. Try for tight control early in the course of the disease. It is worth it in the long run. That is your metabolic memory. So who are the candidates for the tight control? Short duration of the diabetes, long life expectancy, no significant cardiovascular disease at this juncture. Okay, so they are the candidates for the tight control. So those getting the diabetes at 20 years, 30 years, 40 years, so they are the good candidates for the tight control because you have the long life expectancy. So they have to live for 50 years, 40 years, 30 years, etc. Candidates for less tight control. Suppose you are diagnosed with diabetes at 75 years of age group. So less tight control because their lifespan is maximum another 5 years to the 10 years or 15 years. So history of the severe hypoglycemia, limited life expectancy, advanced micro and macrovascular complications, extensive comorbidities, and long duration of the diabetes. So that finishes our today's talk on acute metabolic complications. So next module will be on the chronic complications. So the chronic complications divided into micro and macrovascular. Here this is a retinopathy. So the picture is retinopathy here. And this is kidney biopsy, glomerulus. So the next class we will take up the microvascular complications, your retinopathy, nephropathy and neuropathy. So thank you very much for your patient hearing. If you have any doubts, please